So, hi everyone, this is the second try to record this meeting. So, it's dedicated to cancer, challenges, and progress. And the core thing at the very beginning is to differentiate tumor and cancer. When we speak about tumor, we speak about the abnormal cellular growth. So these cells are usually not modified, while cancerous cells are abnormal and they also divide uncontrollably. Tumor may be benign or malignant, while cancer is always malignant, and we usually speak about epithelial tumor. If we speak about the specific treatment, tumor usually doesn't require it. So we usually send the patient to the follow-up. He gets observation from time to time in a specific regimen, or we offer a patient to get surgery. While with cancer, we have a lot more to propose and a lot more different aspects of treatment. So let's speak a little bit on theories of carcinogenesis. There are four main theories. The first one, and the most common one, is genetic theory. It says that cells become neoplastic because of alterations in the DNA. The mutated cells transmit their characters to the next progeny of cells. So when we speak about the changes in genome, we usually refer to a mutation in a gene that may increase cancer risk here. The evidences that are used as a proof for this theory say that many physical and chemical agents causing cancer bring about mutations in the host cells. For example, when we speak about the viral theory, we usually refer to the HPV, human papillomavirus, and associated tumors. When we speak about the physical agents exposure, the example of the induced by the damage of the ultraviolet rays exposure of skin, which is called xeroderma pigmentosum. It's also a rare hereditary disorder prone to develop skin cancer. And we usually speak about the concept of activation of growth-promoting oncogenes and induction of some consents and inactivation of growth-suppressing anti-oncogenes in a few others. However, this theory wasn't full before because the people didn't really understand the difference in between somatic and germline mutations and how they work, why some people get only a risk of the cancer but are fully healthy and live their life properly, while others develop cancer. And here comes the Knutson's two-hit theory of cancer causation. This is the one that is also used to explain the BRCA-associated cancers. So normal cells have two undamaged chromosomes, one inherited from our mother and one from our father. These chromosomes contain thousands of genes. People with a hereditary susceptibility to cancer inherit a damaged gene on one chromosome, so their first hit or mutation occurs at a conception. Other people may receive the first hit at a later stage, before or after birth. In either case, if a cell receives damage to the same gene on the second chromosome, that cell can produce a cancer. The next theory is epigenetic theory. It says that the carcinogenic agents act on an activators or suppressors of genes and not on the genes themselves, and result in the abnormal expression of genes. So these changes are usually associated with long-term processes, such as diet. And we need to understand that it doesn't usually work alone. Examples of tumor genesis based on the epigenetic theory alone are pretty rare. Immune surveillance theory says that immune-competent hosts induces the attack and development of tumor cells so as to destroy them, while immune-incompetent host doesn't. And this is what happened to the cancer cells. So the proof on this matter is that the observed high incidence of cancer in immunodeficient individuals, for example, those who have AIDS, and the fact that most cancers occur more frequently in old age, when the host immune responses are weak. The last but not the least, monoclonal hypothesis says that most cancers arise from a single clone of transformed cells. And the evidence on this says that many hematopoietic malignancies, cell surface markers can be used to establish their monoclonal origin. So basically, when they undergo the molecular profiling, they are found pretty similar. So as you may have seen, the tumor development is a pretty long process and needs to undergo lots of different stages. So let's take a look at the simplified scheme. There is a normal cell. Let's speak about the epithelial one. It undergoes initiation. So it is usually associated with a gene mutation, and the pathologist would observe hyperproliferation. Then hyperproliferation undergoes other factors, and this change is called promotion. It evolves into the adenoma, a benign tumor, and then it moves on to the propagation stage. So this is the one that is associated with malignification and metastasis formation. And the vital part of these whole processes are taking place in the microenvironment of the tumor cell. So basically, in this microenvironment, a lot of molecular factors are circulating, and they create the place where a tumor cell can live its life pretty wealthy, having enough nutrients and enjoying itself. So if we take a look at the changes on different stages, at initial stages, cancer cells recruit stromal cells, normal ones, and this one is usually associated with the tumor growth factors and interleukins. Then cancer-associated fibroblasts facilitate epithelial mesenchymal transition through growth factors and stromal remodeling. So we see the changes in the molecular stromal components such as collagen and proteoglycans. Then we move on to the angiogenesis, and then the metastatic formation is induced. So the clinicians usually are more interested not in the pathological features and the biology of cancer, but in the epidemiological data. So the best resource of epidemiological cancer information right now that counts the information from all the countries, from all over the world, to be exact, in 185 countries and 36 types of cancer. And this is Globicon. It's a website empowered by the World Health Organization and International Agency for Research on Cancer. And if you go to this website, you move on to the category Cancer Now, and you select what kind of data do you want. Do you want to see the incidence in different countries or through different localizations. For example, this is the map on the distribution of all the cancerous incidents for both sexes, all ages through the countries. So this mission, Globicon, also produces reports, the statistics reports each year, and the one that is most referred to right now is the Global Cancer Statistics 2018, and it says that there will be an estimated 18.1 million new cases, 17 million excluding non-melanoma skin cancer, and 9.6 million cancer deaths in 2018. In both sexes combined, lung cancer is the most commonly diagnosed cancer and the leading cause of death, closely followed by female breast cancer, prostate cancer, and colorectal cancer for incidence, and colorectal cancer, stomach cancer, and liver cancer for mortality. So, if we think of the data for the Ukraine, we have a proper collection of the epidemiological data of Ukraine gathered in Ukrainian National Cancer Registry based on National Cancer Institute, and they provide quite a lot of visual data. So if you go to their website, you may find, for example, the relative frequency of 10 leading cancer sites, incidence, and mortality for the Ukraine, and you may see that the trends, the global ones that I've already described, are pretty similar for the Ukraine. So you may see high incidence rates for females in breast cancer, uterine cancer, colon cancer, ovarian cancer. For males, it's prostate, stomach, colon, rectum, and anus cancers. And this data enables the government to plan the budgets and to spread the specialists to see which need is more sufficient and which requires more attention. And after the epidemiology, they start thinking about the diagnosis. So you may see that there are several steps. Taking anamnesis. If we speak about cancer in general, this would usually include some kinds of headaches, dizziness, concussions, even when the patient may fall unconscious. But it may also be associated with some more local symptoms. For example, for the gastric cancer, we may speak about the nausea, vomiting, constipations, or other changes of stool, etc. So the problem in here is that the manifestation of the cancer usually comes at pretty last stages for many localizations. And we really need to take care of the prognosis of this patient. Physical examination. For some cancers, for example, those that are localized in the breast cancer, the palpation would be enough to see, to suspect any kind of malignancy or benign tumor, whatever. The patient can do it herself, and this is pretty simple. But for many others, the physical examination doesn't give the appropriate understanding to differentiate cancer from other pathologies. And for that reason, the patient would be sent for the laboratory tests. And in here, we also see pretty different changes. So for example, we may see the changes in the lymphocytes and leukocytes and thrombocytes in the blood tests. We may see the presence of the inflammatory factors such as C protein, even though cancer isn't the inflammatory process. And this is also pretty variable, but it enables the clinician to control the situation better. So when the patient is suspected with the cancer, he usually or she is usually sent to the instrumental and radiological examination. This includes endoscopy, CT scans, ultrasound, etc. And they enable the clinician to see the visual aspect of the problem. Is there any kind of change in the tissue? Is there any chance of using the contrast? And here is the core thing. This area is developing pretty rapidly. We see the changes in the possibilities that and capabilities of the, for example, ultrasound apparatus. We may also see the new contrast medications to perform these procedures. But they are still not enough to say that this is cancer, and for that reason a biopsy is performed. Let's take a look at how it's done for the skin cancer. Okay, as the video doesn't really load, let's just say that there is a specific needle that is used to take the sample of the tissue of the patient. It may be also performed during the operation, and this would work for those who are undergoing the surgical procedure to delete the new ungrown thing. If we speak about the after that, when we have performed the biopsy, the sample of the tissue is sent to the pathologist and it undergoes the pathological examination. And here we speak about clinical and gross features of benign malignant tumors, also microscopic features, growth rate, local invasion, metastasis presence, and prognosis. So you may see that if we speak about the malignant tumor, it usually has purely circumscribed and irregular boundaries. Surrounding tissue is usually invaded. They are often larger and they occur more often. When we speak about the size of the tumor, this isn't the appropriate prognostic criteria. Why? Because, for example, if we speak about the endocrine part of the pancreas and the tumors occurring in these cells, so these are insulomas and glucagonas, These are usually pretty small, they are up to 1 centimeter, but still they are really malignant, and their progressing is associated with many clinical complications. So this isn't the very exact factor. When we speak about the microscopic features, we need to understand that malignant tumor usually shows the changes in the molecular profiling, the changes in the nucleocytoplasmic ratio, the changes in the nuclei themselves, and the most important ones are the changes in the mitosis figures. So if we speak about the benign tumor, mitosis may be present but are always typical mitosis, while for the malignant ones, mitotic figures increased are generally atypical and abnormal. And there are lots of other patterns you may look through on this slide. But the real pathologist doesn't really think of the exact whether it's benign tumor or malignant tumor. It's still important, but what's more important is to identify the exact type of tumor. And for that reason, World Health Organization produces several classifications for lots of localizations to show how the cancerous cells are changing, what is the size of the tumor, how this should be diagnosed, from which tissue it's derived, etc. So there are pretty a lot of factors. And afterwards, after the exact tumor is identified, it undergoes T&M classification. So T stands for the tumor. When we say T0, it usually means that no tumor is identified in the organ. When we use T from 1 to 3, it usually shows the size of the tumor present on the slide. If we speak about other marks, which are TX, it goes for the unidentified tumor. So the examining specialist isn't sure whether the tumor is present or not. The TIS symbol means tumor in situ. So these are the changes that are not affecting the basal membrane. N stands for nodes. So N0 means that there are no metastases in the lymphatic nodes. T1 stands for the local metastasis to the local nodes. And T2 usually stands for the distant metastasis in the distant lymph nodes. When we speak about M, it means metastasis, and this one is way more similar. It's either 0, meaning that there are no metastases in the organism, 1, the presence of metastasis, and X, which means that there are several areas where the metastasis may be present, but they can't be diagnosed, and that is the problem. If we think about the staging according to this scale, we need to understand that when there is a metastasis, this usually makes the staging jump to the stage 4 of cancer. And this is pretty important. Pathology is also evolving through the time, and right now we have way more types of staining for different kinds of tissue. We have way more newer techniques, and we have more apparatus options to take a look through the different cells. And if you take a look at these pictures, these are the fibroblasts found in the microenvironment with different stainings. and these are pretty useful for the exact diagnosis. And you may see the examples of immunohistochemistry, this colorful panel. And this field is also evolving and changing through the time. Let's move through the metastases a bit shortly, because this field is pretty broad. So cancer cells can grow into a tumor, cause new blood vessels to grow, which is angiogenesis, undergo physical changes, that's just epithelial mesenchymal transition, and invade through the extracellular matrix and get into the bloodstream, which is intravasation. Circulating tumor cells must survive circulation until they extravasate into a secondary site. Once there is a disseminated tumor cell, they can either grow into metastatic tumor or go dormant. Metastasis may spread through blood and lymphatic vessels, liquor, nerves, and direct contact called carcinomatosis. For many cancer types, we already know the most common sites of metastasis. This is based on the clinical data, so as the pathologists were examining different types of cancer, you may see that for some localizations, the hemopoietic metastatic process is more common, for some lymphatic works better, etc. So the treatment options involve pretty many kinds of techniques right now, and they are evolving through the time. So if we speak about the surgery, right now the oncology can propose a patient manual surgery, the basic one, laparoscopic surgery, and robotic surgery. And right now there are pretty a lot of researches undergoing to understand, is there a difference for the patient, for the prognosis of the patient, if the patient undergoes laparoscopic surgery or manual surgery, the changes in between robotic surgery and manual surgery. And this is a growing field, as the data is still controversial, even though we have more than 20 years of study in this area. If we speak about the chemotherapy usually works with the chemical substances that may stop the cells from the division. This may be called a static effect, or they may induce the apoptosis, or they can modulate the immune reaction, so the cancer cells would become visible. And we also see pretty a lot of changes in this area. For example, we see more targeted chemotherapeutic medications. We see, for example, the receptor-associated chemotherapy. We also see different types of delivery, so there on the picture of the video you may see how the hyperthermic intraperitoneal chemotherapy or HIPAC looks like, and this enables the patient to get a bigger dose of chemotherapy, but in a shorter time, and getting it more accurately in the abdominal area, and this enables the patient move to a better prognosis. The radiotherapy, its core principle is the fact that during the cell division, the cell is the most susceptible to different types of radiation. And this is why the radiotherapy works this good. However, there are several types of them. So for the radiotherapy, we may use alpha particles, beta particles, we can use protons, etc. And all of them have different depth of penetration through the tissue, so we always need to understand that it's pretty hard to make the radiotherapy targeted, even though we have way more options right now. So the radiotherapy may be undergoing under the control of MRI or CT, usually MRI, and it enables the radiotherapies to deliver a more accurate treatment for the patient. The last but not the least, a new field in the oncology is immunotherapy, and this enables the human organism to fight the cancer cells better. So it helps the immune system cells to gain their immune competency. They provide different new options for these treatments, etc. Usually when we speak about any kind of cancer treatment, we speak about the combination of some of them. So some patients would be receiving surgery chemotherapy, some would be receiving surgery chemotherapy radiotherapy, some would be receiving immunotherapy surgery or immunotherapy chemotherapy. And these regimens are tailored specifically to the patient, and this is why the multidisciplinary approach is so important for this field, and the fact that personalized approach right now is such a trend, and molecular profiling is important. Prevention. After undergoing the treatment, patient always goes with the secondary prevention, but the primary prevention is pretty similar. So this says that the patient should keep a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruit and beans, limit consumption of fast foods and other processed foods high in fat, starches, or sugar, limit consumption of red and processed meat, limit consumption of sugar-sweetened drinks, limit alcohol consumption, and do not use supplements for cancer prevention. For mother, the breastfeeding the baby is recommended, and following the recommendations of the clinician you are working with is really important. Let's move through the quiz. As usually, we have some statements for you to say whether they are true or false. As this video is recorded a bit post factum and there are not so many viewers, we'll leave approximately 30 seconds to each statement for you to think if it works or not. So statement number 1, only 5 to 10% of cancers are entirely hereditary. And this statement was true. Most cancers develop through a combination of hereditary and environmental factors, including smoking, alcohol, obesity, and diet. Statement number 2. Eating sugar makes cancer worse. What do you think? Is it true or false? And this statement was false. Actually, research has shown that cancer cells consume more sugar, glucose, than normal cells, but eating sugar will not make your cancer worse, or that if stop eating sugar, the cancer will not shrink or disappear. However, high sugar diet may contribute to excess weight gain and obesity, which are associated with an increased risk of developing several types of cancer. Statement number 3. Cell phones don't cause cancer. This statement was true. According to the best studies completed so far, cancer is caused by genetic mutations, and cell phones emit a type of low-frequency energy that doesn't damage genes. Statement number 4. Dyeing hair can cause cancer. This myth is a strange one that actually has some root in its truth, so it's false, but part of this myth stems from studies done decades ago when information about cancer causes were less common, where certain chemicals used in hair dyes were found to be cancerous in animal testing. Since the 1970s, most of these chemicals have been removed from hair dyes, and modern studies have found no increased risk of cancer in people who dye their hair. Statement number 5. Cancer is a modern disease. What do you think? Is it true or false? This statement was false. The cancer has been known for thousands of years and recorded by ancient Egyptian and Greek physicians. One of the biggest reasons why cancer is a lot more common these days is mainly due to a combination of a longer lifespan and more information. So if we speak about the increase in the incidence of cancer that is expected to the 2030s, that it would be doubled or even tripled. It is associated with the fact that during the lifetime we have a lot of gene mutations undergoing through our organism, but most of them are recognized by our immune system or by the mechanisms of apoptosis. They undergo the cell death, and that's all for them. But as the immune system is also getting old and doesn't work as hard, moreover, more mutations are happening through the time, you may see the accumulation of the risk for the cancer, and that may lead to this problem. Statement number 6. women who have no children or who have their first pregnancy after the age of 30 have a slightly higher risk of developing breast cancer than those who become pregnant while they are younger. This statement is true, so the altered age of maternity works as one of the risk factors for the cancer. Moreover, breastfeeding reduces the risk of breast cancer slightly. So basically, trying to keep the pregnancy as normal as possible is the option here. Okay. Let's move to the last statement. Processed meat causes cancer. Do you think it's true or false? This statement was true. The International Agency for Research on Cancer has classified processed meat as a carcinogen, something that causes cancer, and it has classified red meat as a probable carcinogen, something that probably causes cancer. So this is the end of our short mini lecture for today. So thank you very much for joining us. We are very sorry for the technical complications we've underwent, but still, we've done it properly. Please subscribe to our Telegram and Instagram. We have updates on our social networks. On Telegram, we perform some quizzes for you. On Instagram, you may find some info and vocabulary from our lectures being put together. Don't forget to subscribe to our YouTube channel, and we have an incredible opportunity for you to meet the expert on our upcoming meeting this Friday. So, 4:30 here, YouTube channel of My Medical English UMSA Kyiv. Thanks for joining us. Bye bye.